Welcome to Your Eye Show. I'm optometrist Dr. Ed Wallington from delivercontacts.com, and today we're going to be talking about this new movement and slowing down the progression of nearsightedness called myopia management. Okay, it's okay if you haven't heard of it before, because really it's kind of new. Okay, it really wasn't long ago till I knew of it, and when I did find out about it, I didn't really believe it, and it took a bit for me to kind of latch on. So if you haven't latched on yet, stick around because I've converted. I'm a believer now. Okay, so and it's really something that has a lot of substance to it. So stick around. Hear what I have to say here. So not too long ago, a few years ago, when all we knew about myopia, I mean, we thought we knew everything we needed to know about myopia. Okay, so with myopia, light's supposed to come in and focus at a point in the back of the eye called the fovea. Okay, when we give you glasses or contacts, that's our job. We just make sure light hits the fovea. But if light focuses on the fovea without glasses, we call that emetropia. Okay, the length of your eye is just right for the focus of your eye. Everything matches up. Between the age, from the time you're born to about the age of 5, your eye tries to grow into this state, and it's usually pretty good at it. After the age of 5, though, your eye can continue to grow in length, and if the optics don't keep up with it, okay, then we have to chase down that growth with glasses. Okay, so let's say that the eye grows a little bit beyond the point of focus. Okay, let's say we have to move that point back a certain distance. We measure light in terms of diopters. So if you have to move that point back 1 diopter, okay, to get that point back, then we give you a -1, because we have to move the point backwards, a -1 prescription. If the eye continues to grow, okay, then we have to, let's say, give you a -2 or a -3. So the longer the length of the eye, the higher the dioptric power we have to give. Okay, so when the eye changes, the eye will change in, hundredths of a millimeter at a time, or a tenth of a millimeter at a time. To give you an idea of how much that is, I mean, the thickness of a dime is a millimeter, right? Okay, so a tenth of a millimeter, a hundredth of a millimeter, okay, that's not much, okay? And those little progressions can mean, up to a diopter of change or so. So small progressions anyway lead in millimeter changes in length of the eye, called the axial length, lead to higher dioptric power, necessary to fix the eye. Okay, so and when that eye grows in length, we've always known this. When that eye grows in length, well, the neural elements, the retina, okay, the retina is part of the fovea. The fovea is the most important part of that retina. The retinal elements get stretched along. Okay, so the retina doesn't keep growing with this growing eye. The retina gets stretched with that growing eye. Okay, so the more the eye grows, okay, the greater the risk of disease. Okay, we know that the risk goes up with myopia once you get to the longer your eye. Okay, forget about dioptric power. The longer the eye, the longer that axial length, the greater your risk of developing certain eye problems. Now, in the past, we never really looked at the axial length. We looked more at just what the power was, okay, because there is an association there, right? So if you need a -6 diopters, we go, okay, that's considered high myopia. Your risk has just went way up. Okay, so your risk of that retina being stretched and thinned in a retinal hole, or damage to the myopia, or to the macula and the fovea, are much higher from that myopic progression. Okay, so we've known this all along, that the higher the power, but we really never associated with the axial length. Okay, so now we know. And as we've been paying more attention to it, is that sometimes you don't even have to have a really high power. If that axial length is longer, that you can have a higher risk. Okay, but these are things that aren't really that big of a surprise, because we've always known that. But we've always known that we can chase it with the prescription. But we always thought that, hey, we can't really do too much about stopping that progression because it's already genetically in there. Okay, mom or dad gave you this gene, or grandpa gave you this gene for your eye to grow, and your eye was just going to grow in length, and we would just chase it with prescription. Okay, so a lot of times parents would say, well, can my kids eat carrots and make this better? Nope. Sorry. What if they stop reading and stop playing their video games, or nope. this is, what it is what it's going to be. Let them, feed their mind. Do what they got to do. We really never truly associate with anything other than genetics. All right. So, but what has happened though? What has happened over these last 10 years or so is we've had some minds that have really been paying attention. Even the last 20 years, we've had minds paying attention to different things that we've been treating the eye in different ways. And some people that have been watching what's going on go, hey, this is when I do this to the eye, we can the eye these people's eyes don't seem to get worse, or there's been some bright minds really paying attention to to how what makes they've been making correlations going when a kid that is exposed to this tends not to have a longer eye. Okay, so we started figuring out that we might be able to do something. Okay, so the problem with that is that when they started talking about some of that stuff, there were things that I wasn't really big on, and some of the statements that they made were more correlative. They weren't really based on research. So I kind of got a bad taste in my mouth right from the get-go for when they started talking about this. And so did some of my colleagues when they started talking about myopia management. We weren't big believers in it in the early stages because there wasn't a lot of data there. Okay, so if you still see a doc out, or your doc out there isn't practicing myopia management, realize that it's because there wasn't a lot of data. So anyway, so I'm kind of getting ahead of myself. So what myopia management is now, we look at this we look at this eye and we go, hey, we can do something about this. We can slow the progression of that eye. We can stop that actual length from increasing in size. Okay, that's what myopia management is all about. It's not about stopping the eye from growing. Okay, we don't know how to do that yet, but we can intervene and we can stop that axial length from growing, and therefore decrease the dioptric power. So that you won't need as high of a prescription, or your kid won't need as high of a prescription. And this is especially important if you know that, like, if you're a parent and you have a -6 or a -9 prescription or something like that. Okay, in the past we were like, nope, this is just it is, but now we can actually do something. Okay, and since higher prescriptions increase the risk of greater vision loss. Okay, so a lot of people that do have vision loss, throughout the world, it's associated with nearsightedness. It's associated with axial length. So if we can intervene, we're not just going to help a few people, we're going to help millions of people across the world as the years go by. So as an optometric community, we're starting to really figure it out, and we're kind of getting over these bumps of going, okay, we're learning. We're gonna start. We're learning what the problem is. We're understanding the problem. We're gonna start teaching it. Now, I'll admit that we don't have it down perfectly. Okay, so there's still a lot to learn. But the cool thing is we've come a long way already, and we know that we can slow the progression. And there's still a lot to learn, which means that there's going to be improvements along the way. Okay, we're going to be able to better apply this and maybe even slow the progression down even further. Okay, so this is revolutionary. All right, so your kids are now growing up in a time where we can potentially slow down their myopia. In the past, I couldn't do anything. Okay, and again, I was slow to believe it. There still might be some eye docs that are out there to believe it, but when they're not really grasping it, like like a lot of the doctors are, they're doing it kind of as a protective for you. There's a lot of times stuff come out that is misleading and misguiding. And in this treatment, this myopia management, this slowing down progression of nearsightedness, it can cost some money. Okay, it can cost it's going to cost probably over $1,000 a year, for treatment with myopia management. It's going to cost a lot of time. Okay, and each time, more visits to the eye doctor to monitor progression, to make sure that it's being treated properly. If you really want to see if it's effective or not, you got to pay attention. You got to learn something new here too, and then your kids got to be exposed to some of these different ideas, and I'll explain those different things that we'll do, and you got to accept it. You got to roll with it. If you want to do it, but you don't have to. Okay, so when we present this myopia management, it's an option for you. It's not an absolute, but there's a lot of data supporting that this is real. Okay, so what exactly is it? Let me continue on with what it is. So again, between 0 and 5, your eye is trying to develop. You're trying to figure out what its normal is, and then after the age of 5, till you're done with your growing years. So the biggest years of growing, I would say 8 to 16, but really after 5 to 16 is where the growth. So when the body grows, well, guess what? The eyes grow too. So the greater the body grows, the greater the eye is going to grow. Okay. Matter of fact, if you go to your regular doctor, and as you're watching your kid grow, quite often the doctor will bring out this chart, and they'll say, hey, if you're a boy or if you're a girl, depending on how many inches your child is and how old they are, they're probably going to go on and be this tall. When they're older, Joey's going to be this tall, or Jenny is going to be this tall when she gets older, based on how old they are, and generally, if you plot that, they can find this normative data, this information saying how tall the kid's going to be. Now, if dad is 6'5" and mom is 6'2", Joey and Jenny are probably going to be, pretty tall too. You can probably figure that out without even looking at the charts. But even if the charts say something different, you can probably look at mom and dad and go, well, it's probably going to be more, they're probably going to be taller because, the chart's probably off. The charts aren't always right. Okay. But the charts give normative data, and they're pretty good most of the time. All right. And, so that's why they have the charts, is to make sure a kid is following on expected lines. And now they have that for the eyes too. And it's based on axial length. So the longer the eye, the longer that the eye is, like I said, the longer the eye, the greater the risk of certain eye problems occurring. Okay. And that's kind of, as doctors, we look at that. We really look at what we're concerned about is that axial length. We go, hey, the longer the eye, the more stretched that retina, the greater concern for these problems. All right. For us, we're worried about the disease management. We don't want, the disease is more destructive to vision, and, we can't get you back to 20/20. And so we have these guidelines, these normative data, so far for boys, and a separate one for girls. Okay. And, so at a certain age, we expect that the eye, so an eye is like, 22 to 22.5 millimeters for a kid. And the longer it gets, like if it gets up to 26.5, then the kid's going to end up with, high myopia. Okay. Like that -6 that we were talking about. So the longer the eye, the greater the risk. And we're only talking small amounts. So this is very, very small or short calibrated measurements that the axial length is taken from. So it has to be real precise measurements. So anyway, we can chart what your docs are going to want to do is they're going to want to chart the growth of the eye, and and then they're also going to chart the progression of the myopia, and it'll kind of give you more feedback on whether the intervention is actually making a difference. Because what they'll do is they'll probably get a few charted points before they actually start treatment, and then give you a comparison as you go to see if you're doing well, or if they need to add more methods of treatment. Okay. So again, like I said, as eye doctors, we're watching out for pathological myopia, which means that, harmful effects like the retinal detachments and the maculopathy and, thinning of the retina in the choroid, or the blood vessels that feed the tissues of the retina. But I mean, as parents, you might not want your kid's prescription to grow either. So look at it this way. So, for the most part, if we're talking about how much prescription it takes to move a point back to the fovea, usually when you get to about a 0.5 diopter, a -0.5, if we say minus, we're moving it backwards. A -0.5 is about where a kid starts to notice that their vision is going bad. Once they get to a -1.5, okay, now they're not legal to drive in this, at least in my state, in most states, at about a -1.5, you're not legal to drive because your vision is too bad for day or night driving. Once you get to about a -3, that's where the more of the disease stuff starts kicking in, the greater risk for the disease starts kicking in. And really, a kid doesn't really function very well in any setting. Okay, they can see about this far clearly. Beyond that, things get blurry. All right, that's at -3. Okay, high myopia is double that, -6. All right, so myopia management is demonstrated that it can reduce the progression of myopia like 50%. Okay, half. So in other words, instead of your kid going on to be a -6, now they're a -3, or instead of a -3, they're a -1.5. All right, or instead of a -1.5, they're a -0.75. So if we can slow down the progression by 50%, regardless of where your kid is on that scale, half is a lot. Okay, half means a lot to your kid on your end. Okay, I mean, think about quality of life. Okay, being able to drive legally without versus not, being able to see somewhat versus not at all, having the super high risks versus much less risks. High, the prescription the prescription, how thick the prescription is going to be, how thick those glasses are going to be, how much you have to invest into lenses, whether the kid can play sports without their prescription or not, whether they have to do contacts and glasses. There's cosmetically, a lot of kids fight with wearing the glasses or aren't hygienic enough to wear contact lenses. So there's a lot of stuff that goes into that. And as parents, you don't want your kids to have to wear glasses, I'm sure. So you kind of look at one aspect of things, where we look at the health aspect. So as optometrics is concerned, is that we're in ophthalmologic concerns is that, hey, we see this progression of disease associated with nearsightedness, but by intervening, we can slow down that disease process across the world and help a lot of people. But in the meantime, we could also help a lot of people's quality of life. Okay, so again, we're going to weigh one thing and we're going to give you our best advice, but you got to weigh another and then determine whether it's worth it. All right, you got to decide. When you go to the store, you got to decide whether you want the $200 cleats, or the $100 cleats, or the $50 cleats for your kid. There's no wrong answer. They'll all work. But some might have, better qualities than the other. There is no wrong answer. There's no judgment here. You have to make the best decision for your child. And the docs aren't going to judge, but we are going to do our best to share that information with you, enough information like in this video here, so you can make the best judgment for you and your family. Okay, so let's talk about what myopia management actually is. How do we actually get involved into it? So first thing that we do, and this is a lot of correlative data. Okay, so first thing that we suggest that the free stuff is 2 hours a day outside. All right, so we're starting to find that a lot of the correlation is, hey, kids that spend more time outside don't have as many nearsighted problems. Okay, so like I said, the correlated part that I'm seeing here is that, okay, well, if a kid is nearsighted, they're not going to want to go outside because they can't see far away, and kids that can see far away are going to want to go out. so there could be that, but there's also a lot of studies that are saying that hey, sunlight has a effect on our receptors in our brain, and somehow encourage the growth of the eye because you're not getting this sunlight. Okay, so apparently sunlight in the time outside makes a difference. So now, again, as an optometric community, we're saying we recommend 2 hours a day outside for your kids. That can't be too bad, right? Another thing that we say is avoid the really close up work. Don't go with it inside 12 inches. The more you have to work, the more those muscles inside your eye, the ciliary muscles inside your eye have to work and cause more focus. And that seems to have an association on the growth of the eye. Again, this is one of those things in the past that I didn't have a problem with kids working up close. But apparently there is an association with excessive focus up close. So push that stuff back at least 16 inches. We have this distance. If the kid can put their knuckles in their fist between the, so a lot of kids will grab their phones and bring them right up here. We don't want, you got to help your kids out so they don't have these problems. Get them in a good habit of holding their phones out here or pushing that screen as far away. Working with stuff across the table rather than right up on their face may help slow the progression of myopia without even any other intervention. If your kid does have a prescription, they don't have any kind of this myopia management stuff, well, they should at least be wearing their regular glasses, okay? So not having the best correction, if you don't have the best correction on, that seems to trigger a growth in the eye as well. So greater working distance, outside time of 2 hours, and wear your best correction. In a half hour at a time max. Okay, so when your kids are working, if they spend 30 minutes, if they're doing 30 minutes of work, they need to take a break after that. Okay, take a rest, go do something else, and then come back and get to work. But no more than 30 minutes at a time doing up close work. Okay, I know it's easy to get swept away when you're doing up close work, but no more than 30 minutes for these kids in these years where their eyes are growing. So that's the behavior way. Okay. So now, and then we also have methods of helping the eye from growing that are seeming to work. Okay. And the main thing that seems to be making a difference is this peripheral defocus. Okay. This hyperopic defocus that our eye experiences. So again, like I said, the way that we would treat myopia is we would say, hey, let's move that point of focus onto the fovea. Okay. And this is something that I really never thought about. I only thought about that point of focus. We got to get light focusing on this fovea to help this kid see. All right. But apparently this is when we focus like that, there's a plane of focus. Instead of light focusing on all points of the fovea around the arc of the retina, it's more of a focus in a plane. Okay. So it's more of a flatter plane than following the curve of the retina. So if light focuses behind that retina, apparently this peripheral area that is not in focus, where the light does not focus on that retina, is stimulating that eye to grow. Okay, so that somehow there's a feedback that peripheral retina that we're really not even using except for motion and stuff, there's something in there that's stimulating our eye to continue to grow in length. All right, so we're finding out that if we can bring those points closer, okay, that peripheral defocus closer onto the retina, that we can slow the rate of growth, and that seems to be making a big difference. We can do that in the form of soft contact lenses. We can do that in glasses. All right, in the soft contact lenses, there's a couple of different designs, and the main design I would say that's out there is the dual focus lens with the MySight from Cooper Vision. Okay, so the MySight Cooper Vision is an OMA Philcon A lens, so it has a DK of 25, which means it's not a real breathable lens, but it's a one-day disposable lens. So great for a new kid who's have very healthy eyes anyway. They put a contact lens in. It should fit very comfortably, and they just throw it out at the end of the day, and they put a new lens in every day. So what these MySight lenses have is they have an area of center to get light focused on that fovea, but then it has a ring of that peripheral defocus, and then it's got a ring of clear and then a ring of defocus. So it concentrates on that fovea to make sure that the kid can see well, but then the parts of the eye that the kid's not paying attention to, the peripheral, it's actually working on that so that the retina in the brain that sees it will stop that eye from growing, and that has proven itself, like I said, as about 50% decrease in the growth of the eye. Okay, so that's a good one. That's an easy one. So if doctors out there who aren't practicing myopia management, if that's all you want to do is just fit this contact lens as your mainstay, well, great. It's a great way. It seems to be one of the better ways to in most simple ways to manage it for myopia management. Okay, so even if you skip everything else, if that's all you do, that's a great start. Okay, so there's another lens out there from Cooper Vision that is it's called the Biofinity lens, and it's a plus 50 dominant. Plus, it has a center. It has the center prescription, just the focus light on the fovea, like I said, and it's normally a bifocal lens. Was used as a bifocal lens, but it has a periphery of near. Okay, so it has a plus 250 near, but it's called a D. It's called a plus 250 D, and it's generally used in the dominant eye. So you're so with that lens, it's got for children, it'll have that center area for the distance, and then that peripheral that we tend to use to help us see up close is used as a peripheral defocus zone. All right, so it's another way, but the MiSight is the only FDA approved lens out there right now for this myopia management. Okay, now AccuView is actually coming out with the lens too. Okay, so that's called the Ability, and the Ability is also a one-day disposable lens, and it's actually showing a lot of success as well. So it has a lot more plus out in the periphery that kind of acts more like this. It's like that center distance of the biofinity, but it has a much higher peripheral defocus than that plus 250 zone. That one has a couple of different designs that they're working on and figuring out which one is better. And it sounds like the one that has more power, more plus power out there seems to work more, but the one with the more plus power also has a smaller center zone. So we'll see what happens with that one, but we'll probably have its own video later about that. AccuView also has a new lens out too, that's called the Ability, but that lens is an Ortho-k lens. All right, so don't get those mixed up. An Ortho-k is another way of treating myopia for myopia management. And what that is you use rigid lenses instead of soft lenses. And with the rigid lenses, what you do is you flatten, and this has been out for a while, but when it first came out, it really wasn't for treating myopia management. It was for people who wanted to go to sleep with hard contact lenses on, flatten their cornea with these hard contact lenses. Okay. And then when they wake up, they change the shape of their cornea so that light can focus on their fovea again. Okay, so they manipulated the shape of their cornea to alter the optics of their eye. Well, again, the astute doctors that were doing these fits are like, hey, how come our kids aren't, their myopia is not getting worse? So apparently there's an association there, and it's associated with the axial length. It's kind of hard because like I said, we measure the axial length in hundreds of millimeters, and when you distort that cornea, you're changing the axial length, because the axial length starts with this front cornea, and you're flattening that cornea. So, and there's a warpage effect that takes time to resettle. So it makes it very hard to check to see if that axial length is affected as much with that Ortho-k procedure. So that one is shown its benefits. I wouldn't say it doesn't appear to have the absolute details like the MiSight does, that support it, but it definitely has a place here in myopia management. The next way that we need to talk about is getting involved medically or with drops, with medicine for the eye, with drops. So again, and what they do is they have low dose atropine. So again, somebody was using atropine for other things with the eye and started to realize that, hey, these kids that are using atropine aren't progressing. Their nearsightedness isn't getting as bad when they're taking this atropine. So they're just being attentive to their patients. And so now we also have a way of administering low dose atropine, because an atropine is an anti-muscarinic drop, and it can affect that, which an anticholinergic, so it'll relax the muscles of the pupil. So the pupil, we have circular muscles around the center of our pupil, and then more radial muscles around the circular muscles of the pupil, but it relaxes the center muscles that make the pupil small or make the pupil constrict. Okay, so in other words, when you put these atropine drops, it causes a dilation effect of the eye. Okay, where eyes get small when it's bright, so and they open up when it's dark. So in other words, if they can't get small when it's bright, then the eye can be a little bit more sensitive to light, right? When if you use these drops, and it also affects the focus muscles of our eyes. Okay, so all that focusing that we do when we look at things up close, or when kids do when they look up close, it affects that focus system as well. Okay, so the dosage, so the different dosages can affect how well a kid can focus as well. So there's the different atropine doses that they have. They have a 0.05, they have a 0.025 and a 0.01 from highest dose to the lowest dose. At the highest dose, as you can expect, you have the greatest effect on your focus. Okay, you lose more of your focus, and you lose more of, or you have more dilated eyes. And at the lower doses, less and less. So, but at the higher doses, you have a greater effect on the myopia. Okay, so now this is a trade-off. Which is more important? As eye doctors, we may go, hey, we want less axial length growth, so we want the higher dosage. So your kids, but as a parent, you got to go, well, do I want that for my kid? Do I want to knock out my kid's developing focusing system? And then their eyes to be dilated all the time? Do I want to have to give my kids aids for up close? Focusing aids for up close, that they have to wear additional help to see up close, or a different pair of glasses to read with because their focusing system doesn't work, or they have to wear transitions or sunglasses all the time, or maybe they play baseball and and it's sunny out and they better wear some sport shades or whatever. Okay, so these are a lot of docs will start off at the 0.25. I don't, unless, you might go to the 0.01 if you are, you kind of want to dabble in it and you want some, but you really don't want to, be putting this drop in the eye in the first place. So you're just going to play it safe. Atropine, though, at these doses, it's been used for a long time, and the side effects are minimal. There's the chance of you having a problem with atropine is low. I mean, atropine has potential side effects if used inappropriately, or but if used correctly, there should not be any problems associated with atropine at the dosage that they're giving it. There's also on top of that, I think I made a point, is that there's also these peripheral defocus lenses. So there's different designs there. The problem with the peripheral defocus lenses, or spectacles, is with at least with the contact, when you look around, the contact goes with you. In glasses, there's a center area where all of your main central vision is, and the wider you get, if you're looking through your glasses and you look through the side of your glasses, well, now you're not looking through that optical zone, you're looking through that defocus zone. All right, so you kind of get that if you're somebody who's over 45 and you're wearing progressives, you know what I'm talking about. You get off to that side zone, it doesn't work as well. Okay, so but if a kid is this is what I always say: if you're wearing contacts, you should always wear contacts as well as glasses, not instead of glasses. All right, so if you're gonna your kids, when they're wearing these contacts or doing these treatments, they're gonna still have to combine these different methods. Some of these different methods. As a matter of fact, most doctors are going to combine different methods. But like I said, if you're a doc and you just want to do one, that's fine. Or if you're a parent and you just want to do one, you want to intervene somewhat, but not all. You're not going to go all in. That's fine. But something is probably better than nothing. There's also some red light and blue light therapies that are coming out that early studies are saying that they're working well. I don't know. Again, when this myopia management came out, I was like completely against it and didn't believe it. And but time has shown that it actually, has it's going to be around for a long time. Okay, this is the future of what I'm going to be doing from year to year now. So it's not going away. This is real, and I'm happy to be part of it, knowing that I can actually do something now for kids. So maybe this red light and blue light therapy will have something. Again, I don't like jumping on a bandwagon before it proves itself. But but it may too, and I'm going to bet there's going to be more things that are going to come out, and I'm going to be, a skeptic about all of them until there's some more studies, and you're depending on who your doctor is, your doctor is going to probably, some doctors are going to jump on the bandwagon right away before it's proven, and some are going to, hold off and kind of watch the studies. Just know your doctor, get to know your eye doctors and what kind of person they are. But generally what your doctors, if they are going to do this, they're going to talk to you about it. They're going to give you options. Have that discussion. You need to, if you want to actually make a difference in whether, how, your kid's prescription as they grow into an adult, cool thing is now you can, okay? Talk to your doctor about that intervention. If your doctor doesn't do it, have a discussion and what their feeling is in, like just for example. So I'm still not big on the Ortho-k, okay? So that doesn't mean that it doesn't have a place. Back when I came out, Ortho-k was new and it caused a lot of corneal warpage, and I wanted nothing to do with it. Well, it has come a long way since, but I kind of left it behind me. Now I'm kind of opening up my eyes more to it and starting to go, okay, well, back then it was like you had to fit a lens 6 times before you got it right, and then when you got it right, it caused a lot of warpage. Now it's they got it down to a science because other people kept up on it and have shown that it is safe, but it still has some of these corneal warping issues that I am not happy about, or that I don't want to partake in. But there's a lot of people that are very skilled out there doing it that I know have a lot of success. What I'm feeding you there is just that different doctors are going to have different feels. So if you wanted to do Ortho-k right now and you came in to see me, I wouldn't do that with you. All right. So that wouldn't be something that I would do, but there's doctors out there that do that. So if you want that done, sometimes it's good to ask that question before. Does your doctor, does this doctor, that you're going into, do you do myopia management? If they say, no, I don't want to do anything to do with it, and you're convinced already, well, again, it's not because that doctor doesn't know what they're doing. They know exactly what they're doing. They just aren't sold on it quite yet. Okay. They'll probably come along as time goes, but like I did. But when they're not, it's usually because they're looking out for you. They don't want to, do any harm, and they're just being really careful and being very, very skeptical of the research. Now, again, there's a lot of data out there supporting this. This isn't going away. We're going to find out more. Things are going to get better and better. Your kid, we have a chance to do something for your young kids. And this intervention can happen between like 5 and 16, 5 and 18. During the growing years of the eye, are the years that we can get involved and potentially do something. Okay, so if you've come this far, thank you very much. Make sure you liked and subscribed. Hopefully you did already. Share this with others who may be interested. And I hope it helped you out, and I hope that you come back and see some of this other stuff that we're doing out on Your Eye Show. I appreciate your time. We'll see you around.